Everybody able to see my screen? Yes, okay. I'm ready.
Okay, yes, thank you. So our next presenter is Hemen Mekonnen from Public Policy. She is a senior. She's conducted research with Dr. David Brady in public policy as well. She's a member of Honors. She's also co-president of East African Student Association. And she will be attending UCLA's Public Health Scholars Training Program in summer of 2024. The title of her presentation is Medicaid Expansions and Black-White Inequalities in Augmented Income Poverty. Go ahead, Hemen.
All right, thank you so much for that presentation. As my name is Hemen, and I'm here to present you the research that I've been working on for the past 2 years. So let's just get right into it. Okay. So I kind of wanted to start off by giving you guys a little bit of background information. My presentation essentially lays around the Affordable Care Act. So the Affordable Care Act, kind of give you like a little background. It's a landmark legislation that is aimed at making health insurance accessible to nearly every American, most precisely about 47 million Americans. It addressed key challenges like high insured rates, uninsured rates, gender disparities, and coverage limitations for pre-existing conditions. The Healthcare Scene Free Affordable Care Act is largely characterized by high costs, private insurance market dynamics. It was largely privatized. So a lot of Americans did not have access to medical care, or those who didn't have coverage often went without the necessary medical care. And so some historical resistance and reform efforts that actually were put in place were, for instance, the Clinton Health Reform Initiative in 1994. This specific initiative was kind of like aiming to overhaul the US healthcare system to achieve universal coverage. As we all know, the US does not have universal coverage, which means this initiative never went through. And this is because this plan faced significant challenges and opposition from various interest groups, including health insurers, pharmaceutical companies, and even like the Republican Party. And so many different reforms were, being proposed until the successful enactment of the Affordable Care Act in 2010 during the Obama presidency. So my research essentially focuses or investigates whether Medicaid expansions before and as a result of the Affordable Care Act reduced Black-white inequalities and poverty, because previous research act as if Medicaid has no dollar value to households, when realistically these free, publicly provided free in-kind benefits such as Medicaid do have real values to households, and better poverty measures should monetize it. And so the research question that I investigated are as follows: how have patterns in poverty and racial inequality in poverty changed with the monetized value of health insurance? And how has Medicaid expansion influenced these patterns over time? And so for me to answer these questions, I essentially used the following data source and study focus. So I used the panel studies of income dynamics, also known as the PSID. So what is the PSID? The PSID is actually a longitudinal, nationally representative study initiated in 1968. And what it does is it takes the same 20,000 people and it tracks them biannually since 1997. So it tracks them, their kids, their descendants. And so what it does is it provides us insights into economic, social, health, and demographic behaviors over time. And our study period was from 2009, 2011, 13, as we see here, 15, 17, and 19. And these years are key years before and after the implementation of the Affordable Care Act. And the reason why we have to, why at least I wanted to, and analyze years before and after the Affordable Care Act was implemented is to allow for a baseline and post-reform analysis to understand the Affordable Care Act's impact on the healthcare access and cost. It also helps me, differentiate between pre-existing trends and those influenced by the Affordable Care Act. So the tools that I was able to use, that I used for this research is known as Stata. Stata is a statistical software package for data analysis and data management. And it allowed me to process and examine the relationship between health insurance coverage and household income. And so once I got a hang of Stata, it took a while for me to kind of learn how to code. But once I did, we went around and constructed different key variables, one of whom was the insurance value variable. And the way I constructed that variable is by building on past research, past professionals like Remler and Foreman's pioneering method on monetizing Medicaid. So what we did was we assigned a dollar value to Medicaid and using the second lowest cost silver plan in the state year specific Obamacare exchanges. After doing that, we annualized the insurance costs, and to analyze the insurance costs, we converted the monthly premiums for the silver plan. We added benchmark indicators, and then we adjusted for inflation to kind of have it be, maintain real value consistency across time. Then we went ahead and augmented household incomes. What that means is once we essentially monetize for Medicaid, we took these, based on these monetization of these health insurances, we calculated household income to include taxes, transfers, tax credits, and then we adjusted for household size depending on how many people are in one household. And then we constructed measures of relative and augmented poverty. I will kind of give you guys what the difference is between relative and augmented poverty as we go on to the results section in a little bit. Okay, so we have a couple of data and figures coming along, so just stay with me. So for table 1, I have this details on monetization and distribution of health insurance. So this study actually shows us how the monetization approach, so adding a dollar value to a health insurance, provides a standardized measure to compare financial coverage across different types of health insurance. So as we can see here, we have different types of health insurances from Medicare to Medicaid, employer-provided insurance, military-provided. We assigned dollar values to all of them. We used the state year specific second lowest cost silver plan, as I mentioned before, for Medicare. And so this was the value and so on. For no health insurance, we did not assign any monetary value because that they don't have insurance for us to assign any monetary value to. And for privately purchased insurance, we also don't have anything assigning to it as well, because that is only reflecting out-of-pocket expenses and not government. And so what we see here, for instance, even for the Medicaid, is that we see in 2009 among Black respondents, there is an increase in coverage between 2009 and 2019. So we see about 17% of Black respondents in 2009 were covered by Medicaid. And then by 2019, there's about 23% of Black respondents covered by Medicaid. And similarly, 30% or roughly 31% of the Black respondents in 2009 were uninsured. And by 2019, about 18% of Black respondents were uninsured. And so we kind of see, this substantial decline of the uninsured rate and coverage increase as well amongst the targeted demographics over a decade. Here we have the table for descriptive statistics. So I kind of want to give you guys the rundown of what a typical respondent looks like for this table of descriptive. So a typical respondent is about 42 years of age on average. They have about 14 years of schooling, and that could be, indicative of high school completion or some post-secondary education. And the, typical respondent is about 61% of them of households have a lead earner who is married, suggesting a predominance of two-parent families as well. But I kind of want to direct your focus over here. So we see that there's a stark contrast between poverty rates among Black populations and the white respondents as well. So we see about 30% of the Black respondents live in poverty, compared to about 10% of the white respondents who are living in poverty. Now, this is a really big gap. This is about 20 percentage point gap in poverty rates between Black and white respondents, which underscores deep-seated, economic disparities. Moving forward to this figure, kind of building off of the last table, we have the black and white divide in relative poverty compared to augmented relative poverty. Now, this is where I kind of want to explain to you what the difference is between relative and augmented poverty. So the left panel is giving you relative poverty, and the right panel is giving you the augmented poverty over time. And so relative poverty are poverty measures that do not include monetary value for health insurance. So health insurance is not included in these measurements. But over here, we include health insurance as a monetary value when we did the poverty measurements. And what we see here in relative poverty in 2019, about 29% of Black respondents here remain in poverty, about 13% of white respondents remain in poverty, in relative poverty in 2019. Comparing it, once we adjust and include health insurance and poverty measurements, we see that the adjusted poverty rates for Black respondents have dropped to about 24% and about 10%, and it dropped for about 10% for the white respondents in 2019. And this is a very significant finding because this kind of shows us how the integration of health insurance value into income calculations significantly alters the poverty landscape. And this finding underscores the impact of Medicaid expansion on reducing poverty among the Black population. But it also, at the end of the day, it still highlights that there's an ongoing challenge of high poverty rates within this community, regardless of this decline. So right here, I have a table, a core three-way fixed effects linear probability model, which means the way we can interpret these coefficients that you see right here as much as how much a variable increases or decreases the percentage or even the probability that somebody is poor. And so the objective of this is to assess the impact of Medicaid expansion on augmented relative poverty. And we want to kind of see the difference in the impact of Black and white populations under the Affordable Care Act. And so for this study, we included for state level controls to adjust for varying local policies and economic conditions as well. But what we can see here is amongst Medicaid expansion states and those who are living in Medicaid expansion states, that Medicaid expansion is associated with a significant reduction in poverty of about 4.6 percentage points among Black respondents. But an unintended finding here is that it essentially increased poverty by 2 percentage points for white respondents. Yes, that was actually really interesting for me. So if we look at the overall impact, so while poverty decreased for African Americans about 5 percentage points, well, technically 4.6 percentage points, and about an increased poverty about 1.7 percentage points for white respondents, the racial poverty gap narrowed by 6.3 percentage points if we add these up together. And this is as a result of the Medicaid expansions. Yeah, so this highlights the complex interplay between, Medicaid expansion and poverty reduction across racial lines. Yeah, so kind of wanted to conclude, including health insurance at the end of the day, like as we saw in the three different figures in table 2 as far in the table 3 right now, including health insurance value and poverty measures significantly alters the way we measure and the way we see poverty and the significant reductions in poverty and how it narrows racial disparities. The three-way fixed effect linear probability model showed us how Medicaid expansions essentially reduce poverty for Black respondents about 5 percentage points, but it also unintendedly increased poverty for white respondents by 2 percentage points. Now, I had initially, funny story, I had initially titled this limitations, and my faculty mentor told me this is actually not limitations, is directions for future research, which stuck with me. But essentially, what I would say would be a limitation or just even maybe a direction towards the future research is that the PSID essentially is looking at Black and white respondents. And so it's not really looking at the longitudinal data and impacts and changes of those 20,000 people based off of if they're immigrants, for instance. Like, we don't have any data for immigrants. We don't have any data for Latinos. We don't have any data for Asians. And so we don't really know how Medicaid expansions, at least for this research, how it's affected different ethnicities and other racial and ethnic groups as well. And it's also a survey data. And survey data has also come with potential biases and errors. Inherent issues with self-reported data can introduce inaccuracies. And so some specific concerns can come with like inaccuracies due to, for instance, like memory errors. Some people don't understand the questions, and so they might not really accurately answer them, or some intentional misreportings because the PSID is also asking questions on their income. So yes, thank you so much for listening.